Hello, I'm Dr. Ahmed Abdelal. I'm an associate professor of communication sciences and disorders at Bridgewater State University in Bridgewater, Massachusetts. And in this lecture, I will be speaking about acquired neurogenic language disorders, and the main focus is on aphasia. And also on the side, we'll be speaking about traumatic brain injury and some related disorders that aphasia frequently occurs with, or we call them comorbid disorders that accompany aphasia at times. And this lecture is for students of intro to communication disorders. So we'll speak about brain damage and what happens in the brain as a result of brain damage and how language is affected by brain damage, and also some of the disorders that are related to aphasia. So generally, when we speak about brain damage, we speak about damage that is caused by something. We call it acquired brain damage. And these include cerebrovascular accidents. For example, when we say cerebrovascular, cerebrum is the area, the big area in the brain that includes the cerebral cortex and the white matter below it. And the cerebrum includes the right hemisphere and the left hemisphere. Vascular has to do with blood vessels. So when we say cerebrovascular accident, it is some kind of accident that causes damage, or that involves damage to the blood vessels that are in the brain that maintain nutrition and maintain health of the brain itself. So strokes are the most common kind of cerebrovascular accidents, and we are going to speak about different concepts that have to do with strokes. So for example, an embolus is some kind of a blood clot or a piece of plaque that is dislodged from an artery. When the artery, usually there are some cases where plaque builds up inside of it, and that makes the artery constricted. So the artery generally is connected to the nervous system in a way so that the nervous system can control the movement and the activity of an artery. The artery, you can think about it as like the neck of a balloon. You can stretch it or you can constrict it. When your body gives signals that there is less blood pressure, there is less blood in your brain, for example, the arteries in your neck and in the brain constrict, they narrow down. So when they narrow their diameter, the blood shoots farther. And so this is a system that regulates the amount of blood flowing into the brain, and when there is high blood pressure, for example, a lot more blood is going up. When you put too much blood into a blood vessel because of high blood pressure, that is gonna put a stress on the walls of the blood vessel. It makes it expand more. And when it does, sometimes that causes abnormalities. For example, the blood vessel might rupture, might explode, and that leads to bleeding in the brain or hemorrhage. So that is one kind of strokes that we call hemorrhagic strokes. And sometimes hemorrhagic strokes are also caused by aneurysms, for example, the blood vessels is like a tube like this, and one part of the tube is weak, the thickness of it is weaker than usual, and a lot of blood pressure pounding on it, it causes that weak, thin part to bulge out and to form a little balloon on the side. So, for example, here. So these balloons are called aneurysms. These little balloons or aneurysms are usually they are inherited. They are genetically based, and people are born with them, and as a result, they grow with the person. As the person grows, these little aneurysms grow with them. If detected earlier, before they explode, the damage will be minimal, and the person does well, and it would be, and as a result of surgery, you can avoid the damage. However, if they rupture, that is going to cause consequences, and depending on how quickly you bring the person to the emergency room, that will the consequences will depend on that. So the consequences could be completely reversed, or if there's a long delay, more than a few hours, then the consequences could be more dangerous, to the extent that could lead to death of the person, because it will lead to pooling, as you could see here, pooling of the blood in the intercranial space, and that pushes down on the soft the soft structures of the brain. The brain is about the consistency of toothpaste, so it is very, very delicate. And when you put pressure on top, under the cranium, that's gonna, with the pooling of the blood, is gonna push down, 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 and the brain has nowhere to go. The structures have nowhere to go. However, if you look at the structure of the brain and the skull, how it is structured, it's almost like a funnel. So as a result, bigger structures that are here are squeezed down toward the brain stem, and that could cause basically large areas of the brain to be squeezed into smaller areas, and gradually, when this case is very severe, it will cause death. So this problem can be minimal, or it can be massive, depending on how big the blood vessel is. For example, lower blood vessels like this, the damage is going to be massive. But little blood vessels that are small, if they have that, the effect of that will be smaller and less severe. And also the time, how fast do you act to bring the person for medical intervention. So hemorrhagic strokes, they result again from two reasons. One is aneurysms, and the other one is weak areas on the blood vessel wall inside of the brain that are aggravated by high blood pressure, and that would cause the hemorrhage in the brain. And then the consequences could also depend on if that is happening in the right hemisphere or the left hemisphere, and how big the blood vessel is. And they typically happen in arteries. Arteries bring the blood from the brain to the rest of the body, so the blood is rushing constantly through them and pounding their walls with pressure. So the other kind of a cerebrovascular accident is the kind of accident that involves blockage of a blood vessel inside of the brain. The blockage is caused by a structure either called an embolus or another structure called a thrombus. So the embolus, for example, is simply a blood clot. And in some cases, a blood clot could happen as a result of a ruptured blood vessel. So that could travel to another blood vessel and it can block it. And when you block it, that area that is innervated or fed or supplied by that blood vessel, all the branches, that would be dead unless you save the person very quickly. So the embolus is a blood clot that blocks blocks one of the blood arteries in the brain. And that can be random. It can happen in the right hemisphere, left hemisphere. It can happen to big blood vessels or small blood vessels. And how big or how small, that's going to affect, and it will determine the extent of the damage and how severe that damage is. So, and also pay attention to this. The blood vessels, from the lower the blood vessel is, the bigger, the larger it is, and the more areas that it will feed and innervate. For example, the right hemisphere, look at this blood vessel, the carotid artery. It just goes up, and a branch of it innervates the entire, for example, one hemisphere. So if you take one branch of it, and say the frontal part here, that innervates the frontal part of the brain. And if you shut this down by a little blood clot, this whole area will be deprived of oxygen, and if not saved fast enough, the person is going to have a massive stroke that will affect the frontal part of the brain. And that is the part that helps us with attention, with working memory or short-term memory. It helps us with decision making, with judgment, with initiating tasks, and it manages our entire personality, our entire system. And for example, someone who has a massive stroke like that would not be able to hold the job and to do well, because basically they would have no judgment, and the damage will impair memory skills and attention skills, work, and also the ability to make judgment, and they would not be able to engage in communication effectively. They wouldn't be able to initiate things. When do I do my homework? When do I do this kind of job? And so on. So again, it depends on where that cerebrovascular accident occurs. The other kind of damage that can happen due to blockage. So the embolus causes blockage. And then the other kind of incident could be a thrombosis, and this thrombosis is a piece of plaque that is it can be even as small as a grain of sand, that gets dislodged from the plaque that is blocking an artery. Usually the plaque, it doesn't, immediately when it begins, it doesn't shut the whole artery. It builds up on the walls around, and then in a specific area. And then these walls, the plaque is hard, and it prevents the blood vessel from contracting, to raise blood pressure, and or dilating to relieve blood, to lower blood pressure. So that is the plaque is gonna cause constant high blood pressure. The more that it becomes thick and it goes around the wall, it constricts the diameter of it. It makes the blood vessel unable to relax to lower blood pressure. So that constantly the blood is gushing through it, and the plaque is not even. It is all like fibrous materials and materials that are jagged and hanging down. So when there's a piece that is hanging down, it is called the thrombus. Once it gets dislodged out of the blood vessel, it's gonna travel upward into the brain. And the size of it, if it's too big, it will block a big blood vessel. If it is small, it's gonna block a smaller blood vessel. But as it comes very quick traveling, and then it just gets jammed into the entrance of a blood vessel, and then it shuts it down. And then everything beyond that is fed by that blood vessel is going to have no oxygen. It's going to have no glucose, and it will be deprived of nutrition and oxygen. So if you save the person within hours, the damage can be reversed. But if it is a long time, the damage will be permanent. So that's the thrombus. So again, the embolus and the thrombus cause occlusive. Occlusive comes from occlusion. They cause occlusive strokes that are simply, very quietly, just block a blood vessel. And the hemorrhage, it is caused by rupturing of a blood vessel. And in both cases, the areas that are supplied by these blood vessels become deprived of the nutrition and the oxygen, and the tissue starts to die. Now, these areas would not be able to function, to give the same functions they usually give. So, in terms of language, these strokes are going to cause some kinds of language impairment depending on where they hit. Remember this, if the stroke or the cerebrovascular accident occurs in the left hemisphere, always we call that aphasia. The damage, that is language damage that is caused, it is called aphasia, or a language impairment. Then there are different kinds of brain damage, for example, that are called, head injury. Traumatic brain injury, for example, that can be caused by car acceleration, deceleration. You are traveling fast and speeding, and you hit an object that is at a slower motion or at not moving at all. So once you slam, that's gonna cause the head to be jerked front to back multiple times, and that's gonna cause damage to different parts of the brain, depending on how severe, how fast the car is, how severe the damage is. And traumatic brain injury can also include concussions, can include bullets going into the brain, can include any hit, severe, major hit to the brain in any area that could cause traumatic brain injury. So that's a big area. Also, there are tumors, benign tumors or malignant tumors. The tumors are called neoplasms or new structures that build up. And then also there is brain damage that can be acquired by aging, for example, or not necessarily by aging, but by disorders that occur, and the disease is progressive in a way. As it goes very quickly, it becomes worse and worse very quickly, and it doesn't become better at any time. For example, Alzheimer's disease as a progressive neurological disorder. There are different disorders that are known. Once they come, they just become worse quickly, and they do not become better. So the brain circulation, as part of what we do, is we study brain circulation in the brain. So a good neurology class should give you a good background on brain circulation, so that you know exactly what parts of the brain are supplied by what artery. And when you know that, when you get the MRI or brain scanning images and it tells you this is the blood vessel that is ruptured or that is blocked, then you know what areas of the brain are disabled, and then you will be able to go and say, oh, this area enables us to perform these functions, 1, 2, 3, 4. So since it is deprived of oxygen and glucose and so on, so the damage is going to cause the person to have these characteristics or these symptoms, 1, 2, 3. So as a result, again, it is very, very important for us as specialists to understand how the blood travels into the brain, what blood vessels innervate what structures of the brain, and then when we know the diagnosis, like the neurological examination results, we will be able to predict exactly what functions will be impaired. So I'm going to speak first about traumatic brain injury because we are not going to focus too much on it. Our main focus here is on aphasia as caused by strokes. Traumatic brain injury, it causes multiple problems. One, for example, is contusions. A contusion is a brain bruise, for example. Another kind is laceration, which is tearing of the structures and vessels in the blood and the brain. Hematomas are areas where the blood is forced out of a certain area, a certain blood vessel, and it is forced out of it so that it can pool in different areas surrounding that blood vessel, and they show as bruises. Sometimes a hematoma, for example, when there's a car accident, for example, usually hours or maybe the next day after that, if you see around the eye, you see a black circle, black bluish circle around the eyes. It is called panda eyes. That typically is a sign of a cranial fracture, like the base of the skull is fractured, and out of it, the fluid that surrounds the brain, cerebrovascular fluid, leaks out into that fracture, and it finds space around, because the eyes are right below the skull. That blood, the cerebrovascular fluid is going to leak out, and some blood will leak out and pool in the orbits of the eyes, and we know that as panda eyes. And again, it means that most often there is a cranial fracture, and that could cause bacteria, and our noses are not really very clean, and that is going to the bacteria, viruses, and so on could travel to the eye orbits, and then that can cause them to escape and go into the fracture and invade the brain and the spinal, and the brain and the nervous system, the rest of the nervous system. So that would cause meningitis, and it's a serious disease that could be, the person could be helped if that is diagnosed fast enough. It could also lead to death. Usually in a traumatic brain injury, say caused by acceleration, deceleration, like speeding, there are 2 points that are damaged. Typically, like if it's straightforward like speeding and someone slams, one area is, say for example, if this area is hit, first the tissue behind this wall is going to be smashed against the bone, against the skull. It's going to be smashed against it, and that will be damaged. So an area will be damaged here, which is the area of impact. When at 180 degrees, at a straight line from that area, if you make a straight line, you're going to find that this area in the back is also damaged. That's called the counter coup area. So think about it like this. You have a cup that is full of jello, and you take that cup and just hit it against something hard. First, and when you hit, and this wall of the cup that hits the hard object, you're going to see that the jello is going to rise up and will be squished against that wall. That is damage, because the squishing means little axons of neurons are severed, are damaged. And then on the other side of the cup, you are going to see that the jello is dislodged, is separated from the wall of that cup. And that is also a sign of damage, where there is tearing and where the wall, where the tissue is torn on the other side. So traumatic brain injury, it depends on where it hits, what part of the brain is damaged, how severe the injury is, and so on. So the effect, again, is going to depend on the severity and the area, the location of the lesion. For example, in the left hemisphere, if there's a damage, the accident involves the left hemisphere, that is going to cause it will cause, comprehension problems, auditory processing problems. It will cause language damage to the language centers. It will cause, basically, communication will be impaired to various degrees. If it's in the right hemisphere, emotional processing, being able to understand the tone of someone else's speech could be impaired. Being able to speak in a normal tone will be impaired. Being able to process big chunks of conversation, like interactions in a conversation, or listen to connected speech, that will be impaired. Being able to speak and give a coherent description of an event, or a coherent description of something that happens, the person will have significant difficulty doing so, like telling a story that is sequenced nicely, that has a beginning, that has an end, middle details, and an end. Being able to speak with a normal tone of voice, that is also could be impaired if the right hemisphere is the one exposed to the damage. So again, the damage, again, this is speaking about the kind of occlusive strokes that can be caused by plaque building around the walls of an artery, and that refers more to cerebrovascular accidents than to strokes. Than traumatic brain injury. So back again to the description, speaking about strokes, that now we spoke about traumatic brain injury, because we're not going to speak too much about it from now on. These areas here that are damaged as a result of occlusion of a blood vessel, we call this area an ischemia, or we call it an infarction or an infarct. So that is an area where the tissue is dead because a blood vessel is occluded. Again, remember, the occlusion can happen because of one of two causes. One is a clot, a blood clot, or a thrombus that blocks the blood vessel. On the other side, you see hemorrhagic strokes, and you can see pooling on the cranial space, the intercranial space between the cranium and the tissue of the brain itself, and that causes pressure, and that is gonna squirt different pieces of the brain just to other areas. And if that is massive, that could cause pressure to a lot of areas of the brain. Eventually, that could cause many parts of the brain to be squeezed down and toward the brainstem. That could cause death. So let's now speak about a stroke with a little bit more detail. We said the cerebrovascular event is an event that happens to a blood vessel inside of the brain. And the two major kinds of it are occlusive strokes or hemorrhagic strokes. And the occlusive strokes are caused by blockage because of an embolus or because of a thrombus. And the effect of that, it doesn't matter if it's a thrombus or an embolus, the effect is the same, because in both cases you are going to block a blood vessel, and that is going to deprive the entire area that is supplied by that blood vessel. You deprive it of oxygen and glucose and the different chemicals that enable the brain to survive. For the hemorrhage, again, it is caused by either one of two causes. Either the rupturing of an aneurysm, and you know what an aneurysm is now, or by increased blood pressure that can affect a thin area of the wall of an artery to explode, to be ruptured. And in both cases, again, the effect is the same, because in both cases you have bleeding, and that when the blood vessel ruptures or there's an explosion, you have the bleeding, the pooling of the blood on top of the brain or in that area where the stroke occurs. That is one thing. And at the same time, that's going to cause intracranial pressure, where the different parts of the brain will be squeezed down, and it will cause cutting and severing of the axons of the neurons, and that will kill many neurons. In addition to that, the area that is supplied, in addition to the pressure, the area that is supplied by the blood vessel that is ruptured, that area will also be deprived of oxygen and nutrition, and that is going to cause that area to be in danger of being dead. So hemorrhagic strokes also cause infarctions or death of areas of the brain tissue, as you could see here in these areas. So for strokes, we have some concepts that are related to that. For example, edema, that is swelling of brain tissue, and that swelling occurs usually around the side, the lesion, or around the area of damage. The reason for that swelling is that the immune system immediately gets help to the area, and it tries to salvage as much as possible of the dead tissue, and to bring immune system elements so that they can clean up the dead tissue and try to repair the damage as possible. Infarctions or infarcts, these are areas of dead tissue that result from deprivation, from oxygen deprivation or deprivation of glucose or nutrition to the brain. So this whole shaded area is an infarct or an infarction. The embolus, it's a blood clot, and the thrombus is a little piece of plaque that is dislodged from a blood, atherosclerosis or plaque that's inside of a blood vessel. And we also speak about spontaneous recovery, which means that after a stroke or after brain damage, the brain quickly tries to heal itself. So we call that spontaneous recovery. As the brain quickly tries to heal itself, it depends on how long the damage took place, how severe the damage was, and so on. The recovery is going to depend on that. But it is a natural kind of recovery, healing inside of the brain. And as that healing is accomplished, then the areas that were functioning to give you a certain job, a certain function, they start to function better again. So in reality, whether you provide speech services or not, there will be some spontaneous recovery, where the brain by itself, it heals and it regains as much functioning as possible on its own. Spontaneous recovery is marked by an increase in the function, improvement in the functioning. However, it's like a wave. Imagine like the normal waves in the ocean coming in and going back. And the normal waves in the ocean will help you, if you are swimming, to go closer to the shore. But imagine that you have a big wave coming in, and as you are swimming, trying to reach the shore, And as the wave comes, you also swim with the wave. That is going to make you go faster to the shore. When speech language therapy is provided immediately after the injury, that is going to maximize the effect of the improvement. So, and also when there's damage to the brain becomes highly flexible, highly plastic, and that is an area where you can make so much improvement. Amount of time, spontaneous recovery can maximize the improvement when you provide services, whether physical therapy, occupational therapy, or you name it. That is, you can maximize the improvement that the patient can get. So you get the spontaneous recovery, and also you maximize the functioning as well. It's like riding the wave. So now we speak about aphasia, and here is a little video that introduces aphasia, and you see a patient actually who was a neurologist that had a stroke. So you'll find it interesting to see exactly what it is like to live with stroke, to have stroke. So in this, there are different kinds of aphasia. You are not, in this introductory lecture, I'm not going to speak about all kinds. Obviously, I'd like to give you a taste of each kind. I mean, some of them, not all, but also highlight each kind, give you a little background. When you study, you go into speech language pathology as a grad student, you are going to study all the various kinds of aphasia, and you'll have a whole course focused on neurogenic communication disorders. So, Broca's aphasia is known after the area of the brain that is known as Broca's area. That is the purplish area here that is damaged. That area does two things. It enables you to speak in grammatical terms. It has your lexicon or your mental dictionary, and it also enables, it contributes to motor programming. It has the programming, of the muscles, or the templates of how to produce words, how to say words, what muscles do what, and how they come together in a sequence. You can think of this as the software that you connect, that you install in your computer to run a printer. So without that software, the printer is not going to work. The printer will not be accessible. So these grammatical forms, the motor activity of Broca's area is going to create a template. When you send that template to the motor area, see that the area next to it that is part of the motor cortex, that is the area that's connected directly to your muscles of your face, muscles of your neck, all the muscles of speech. So when you send that template to this motor cortex area, that is gonna activate your muscles of speech, and you make speech that is accurate in terms of movement, and also that is intelligible. But so this is Broca's area. When there is damage to it, then if the damage is only to Broca's area, then the damage can be reversed, given that you get the person quickly to the emergency room and so on. If the damage involves damage to the network or Broca's area network, for example, that network includes the frontal part of the brain, and includes also the motor area. It includes sensory areas. It includes areas here in this temporal cortex. So it's a whole wide area that is, if the damage is involving the major network, then you have aphasia or real Broca's aphasia that is going to stay for a long time, and the person will live with it, basically. So when we speak and say Broca's aphasia, we typically mean the aphasia that is resulting from a breakdown or damage to the entire or different parts of the network. So generally, all of these areas here are in the left hemisphere. And I remember I told you that aphasia is the result only of damage to the left hemisphere, because Broca's area is only in the left hemisphere. This area, the orangish kind of area here, is called Wernicke's area. And that is for comprehension and for language production. And also it works, there's a big pathway that connects it with Broca's area. That pathway also passes with, see this lobe of the brain that we know as the parietal cortex, that also connects, the arcuate fasciculus that connects Wernicke's area to Broca's area also connects them with the parietal cortex here. So Wernicke's area works with Broca's area to put sounds together in a sequence to make syllables and words. They also work together to put words together to make sentences. And in addition to that, the connection they have with the parietal cortex is going to give you sensation from your muscles of speech, from the muscles as they move to make speech. For example, when you say, oh, you feel your lips rounded. You get feedback, and that tells you that you are making the movement right. So damage again to Broca's area is caused by damage to Broca's area and some of the network that is connected with it. These are signs or symptoms. How do you know that someone has Broca's area? These are the criteria or the symptoms that the person is going to exhibit. They will have difficulty putting sounds together to make words. They will have difficulty speaking in grammatical forms, difficulty making sentences that are accurate. For example, instead of saying, I would like to finish my homework tonight, they might say, I homework tonight, or I finish homework tonight. So they leave out grammatical words like prepositions, like between, outside, inside, of, to, from. They leave these words out. In some cases, mostly the production is focused on the content words. The content words in language are nouns and verbs. After that, you get nouns, you get adjectives, and with verbs, you get adverbs. So the content words, number one, nouns and verbs, number two, adjectives and adverbs. And after that, you can use any other words like prepositions, articles like the, and so on. All of these are called grammatical words. So the person will have difficulty using grammatical words. In effect, they have difficulty producing grammatical speech. Sometimes we know this as agrammatism, or lack of grammatical or appropriate grammar. Speech, usually the person has difficulty kind of producing speech. The language is awkward. Verbal expression is if not, it is not fluent. They pause, they try to think, and they sometimes can't get a word out. They speak in short phrases and short sentences. The rate of speech is low, and when they speak, their rhythm or the melody of speech, as you notice now as I'm using it, going up in pitch and lower, and going high in loudness and going lower, all of that is impaired as well. They have comprehension skills that are okay if the sentence is short and if it is clear, there is no strange grammar in it. Like you say, the cat walked away, or the cat ate the fish. They do okay with that. They comprehend that. But once you change the grammar, or once you make the sentence too long, they will have difficulty with that. For example, if you say, the fish that I caught was eaten by Tom's cat. when you say that, the person will not be able to process that because it's not normal grammar. I mean, not typical grammar, and it makes it difficult for them. Whenever you say, for example, the box was folded by the girl or was torn by the boy. The apple was eaten by Tom's friend. That is not like a typical syntax. So they will have difficulty with grammatical forms that are not direct and that are complex or long. They have difficulty repeating complex sentences. Like if you say to them, repeat this after me. The girl ate the fish that the man caught. They would have difficulty with that. But if you say, the girl ate the fish, that is fine. They can repeat it easily. Then we speak about Wernicke's aphasia. Wernicke's aphasia here is caused by damage to this area here that is called Wernicke's area. This area is in the temporal cortex, and particularly in the superior gyrus, temporal gyrus, and particularly in that superior temporal gyrus, the area is in the posterior part of the superior temporal gyrus. So that is Wernicke's area. It is extensively connected with the area next to it here in the middle temporal gyrus that is called the auditory cortex. That is where everything you hear comes in. So what you hear is gonna go to Wernicke's area and as sounds, and Wernicke's area works with other areas to take these sounds, assemble them into words and phrases, and also Broca's area helps in that. When you get the word assembled, say the word cat, so initially you get it as ka, t, and then now you assembled it, but then you don't, what is cat? You have no idea what that means. So this area, Wernicke's area, works with the auditory cortex to assemble and works with Broca's area. And also it works with an area in the middle temporal cortex. That area is called the auditory association cortex. Behind the auditory association cortex, there is the memory center called the hippocampus. So that also works to provide you with the concept, with the meaning of the word that you assembled. So cat, now what is the meaning of cat? And the information is sent to this auditory association cortex and the memory center behind it, and then you get the meaning back here and it says, oh, that is an animal that has 4 legs and a tail, it has this and this and this, and then you have the word complete with the concept. Once you have it, then the information travels to the parietal cortex that gives you like a feeling of, oh, the cat, if you touch it, it's smooth, the hair is soft, this and the color is this and that and so on. And then the information then now completed with the sensory description, and then it goes to Broca's area. Now we have one word that is complete with everything. And that Broca's area says, oh, I know this word, it's a noun. And the noun, you can put it at the beginning of a sentence. You say the cat as a subject, or I saw the cat. You can make it an object. And it tells you where you put the word in a sentence, for example, so that you can make an accurate grammatical sentence. So Broca's area is characterized by, I'm now speaking about Wernicke's area. Wernicke's area is characterized by difficulty, for example, with attention, and difficulty with storing new concepts and processing new concepts, new meanings of concepts. And the reason is that now look, access to the frontal cortex here is damaged because this area is damaged. So it can't access the area in Broca's area and the functions in Broca's area. It cannot access the functions in the parietal cortex. It has difficulty accessing the association cortex and the memory center. So as a result, it is not communicating properly with the other parts of the network. So these networks, as I explained, they are responsible for grammatical assembly and grammatical processing, and also the prefrontal cortex. Actually, when you look at this arcuate fasciculus, is the connection that links, as I explained, that links Wernicke's area to Broca's area. It also, when this connection is not working, Wernicke's area can't access that information. It also cannot access the information in the prefrontal cortex, which is the area in front of Broca's area, all of this area behind your forehead. So that information is not reaching the Wernicke's area. So as a result, the person has poor attention, and they also have difficulty processing memory. With memory processing, they cannot recall things. And interestingly, Wernicke's area, speech motor skills are intact. The person can move his lips or her lips, the vocal folds function, everything, all the motor system is fine. And because of that, they call this kind of aphasia, Wernicke's aphasia, they call it fluent. So fluent, don't make it kind of deceive you. It's a word that means simply your motor system is intact. You can speak quickly, but it doesn't mean that the person makes sense. The person just speaks in very strange ways. You cannot understand much of what they say. They make up their own words, and there's no sense in what they say. We call this neologisms. So they just make up words, and they think that they are making sense, but they do not have any idea. They can't monitor themselves. So the person has difficulty monitoring his speech or her own speech. They think they are making sense when they really are not making sense. Let me see. So if you just go online and just Google, say, Wernicke's aphasia, you are going to find samples, videos of patients speaking, and you will see that that they have difficulty making sense in their speech. They will have difficulty repeating what you say, whether words or sentences particularly. They make things, for example, verbal perfection, like they might call a spoon a fork, or they might call a fork a snork, for example. Or it can be any kind of, or dork, for example. Again, they have difficulty processing because that's a comprehension, mostly a comprehension problem, because they have difficulty connecting with Broca's area as well. Decreased attention and difficulty processing or storing new concepts. So now we speak about conduction aphasia, and that is caused by damage to the network that is required for assembling phonemes into words and for coordination of speech sound production. And this damage, for example, can destroy the feed forward and feedback projections that interconnect areas of the temporal, parietal, insular, and frontal cortex. I'm going to explain what this means. So we'll go back to the image here. This is again the network for language comprehension, language production. So when that network is broken, especially the connections, especially there are in that arcuate fasciculus, there are pathways that carry information from Broca's area from Wernicke's area to Broca's. And then that information gets feedback from Broca's to send it to Wernicke's. So it's a two-way pathway. And that interaction here now is disrupted. So as a result, you have, for example, difficulty connecting the functions of Broca's area with the parietal cortex and sensory functions, and with Wernicke's area. So conduction aphasia, again, you can results in inability to channel information back and forth among different parts of the language network, language production network. That is in the temporal cortex, the parietal cortex, and the frontal cortex, where Broca's area is. In addition, there's the insular cortex are also damaged. The insular cortex, you're not going to see it here, but if you simply just take that, there's a fissure here, or a little valley in between this area and these areas. If you just hold it down and hold these other edges up, then you'll see a little island buried beneath these boundaries, and that is called the insular cortex, or the insula, and that contributes to speech. So that is where conduction aphasia comes from. So it is characterized by minimally impaired auditory comprehension. The auditory comprehension is okay, but the damage or the effect on auditory comprehension is minimal. Difficulty putting sounds into words. Difficulty naming pictures and objects. You show the person a picture of a lion. Say, tell me what it is. They will not know, might not know what it means. They might name it something else. If you get an object and say, tell me what this is, they might not know. They might not be able to tell it to you. Spontaneous speech is okay. Speech is generally intelligible, the speech they make. The main hallmark difficulty is in repetition. They have difficulty repeating words, sentences. So there are also literal paraphasias. Paraphasia is like either taking a sound and replacing it by another sound, or a word and naming it. So for example, literal paraphasia means if you say fork and then you call it snork, or fork, you call it dork, that is a literal paraphasia. If it's a whole word, you say bottle, you name it, you name it cup, that will be semantic paraphasia. So literal paraphasia is one of the characteristics of conduction aphasia, and also the person is aware of the problem and they try to correct the speech error they make. Here's a video that is going to show you a patient with conduction aphasia. Please watch it and see how these characteristics are present in this person. Okay, with anomic aphasia, anomic comes from naming. So anomic aphasia, the biggest characteristic of it is that the person has difficulty with naming. Like if you show a picture and say, tell me what it is, they would have difficulty saying what it is. If you show an object, they would have difficulty with that. Retrieving words as they speak is very, very hard. So almost sometimes the meaning is without words. This kind of aphasia occurs due to damage in this area here. In the junction between the parietal cortex or parietal lobe and the occipital cortex or occipital lobe. So the word lobe equals cortex. And the temporal cortex. So in this little triangle where the parietal, the occipital, and the temporal lobes are kind of bordering on each other, then you have that kind of damage. And this causes aphasia. Remember, the parietal lobe has maps, sensory maps of your entire body. And the occipital is responsible for visual processing. When you see something, you see it in the occipital lobe, and it also you store visual images and things in the occipital lobe. And the temporal is language and comprehension. So this person has significant difficulty, this kind of aphasia, with retrieving names of people, names of objects, names of pictures, names of concepts. They make a lot of paraphasias. For example, if you say burger, they might say durger. Or something like chair, they might call it flare. Circumlocutions, that means beating around the bush. When they look at a bottle, they might say, it's the thing, you drink water, you carry it around, it is, so they guess around the meaning of the word, but they're not getting it correctly. They do a lot of beating around the bush. Speech, in terms of motoric skills, motor skills are fine, are intact. But again, it is not just being able to say words. It is about the meaning you make, about the sense that you make when you say words. So again, remember that fluency here is a technical term. It only refers to the fact that the muscular system is functioning fine. They are able to comprehend what someone says. Another kind is transcortical aphasia. When you say transcortical, it means, let me tell you, see the word lobe. Again, it means cortex. We say the frontal lobe, the parietal lobe. Instead of that, we say the frontal cortex, the parietal cortex, the temporal cortex, the occipital or the visual cortex. So when one cortex or one lobe is not communicating well with the other, that results in transcortical, or communication between different lobes is not going well. So transcortical aphasia is caused by widespread damage to the frontal lobe. And if it is frontal lobe damage, it causes motor dysfunction. And the reason is that this is the frontal lobe. See this line here behind that pink line? All of this line here separates. What's ever in front of it is the frontal lobe. What is behind it is the parietal. So the frontal lobe is responsible for motor performance, responsible for motor planning before you perform something. So if there is widespread damage in the frontal lobe or the frontal cortex, naturally the person will not be able to perform motor functions for speech and for other things as well. So the transcortical damage, the aphasia results from widespread damage to the areas that mediate language. The frontal cortex, the parietal, and the temporal lobe, all of these there is damage to them. However, the connection between the arcuate fasciculus that connects the temporal, the parietal, and frontal lobes, that arcuate fasciculus remains intact. Yes, fine, you have it intact, but you do not have, the areas that are connected are not functioning appropriately. It doesn't matter if the connection is working or not now. So in that case now, if the extensive damage takes place in the frontal cortex, that is going to cause motor or transcortical motor aphasia that affects motor skills for speech. And there's also another kind that is sensory, transcortical sensory, that is going to impact the comprehension mechanism. So remember, the transcortical motor is caused by extensive damage to the frontal lobe, and in either case, transcortical motor or transcortical sensory, in that case, the arcuate fasciculus is intact. So then there is widespread damage to the parietal lobe. The parietal lobe is here, and I reminded you that, remember that the parietal lobe has sensory processing for the entire body, and that includes sensory processing for the speech mechanism. Like, for example, say, ooh, you get the sense that your lips are rounded, even if you are not looking at your lips. If you lift up your tongue, you know you have the feeling that your tongue is up and coming in contact with something else. So you cannot get that sensation unless you have intact temporal lobe mechanisms and connections. So as a result, sensory is basically from the word sense. So the person is going to have a sensory, transcortical sensory aphasia because this particular lobe is damaged, and as a result, it's not communicating information to the temporal lobe or to the frontal lobe. And as a result, the person is going to have this kind of aphasia. And the main characteristics of this kind of aphasia are poor auditory comprehension, even though the person is able to repeat what he or she hears. Another kind of aphasia is called global. And from the meaning, from the name of it, you know that it implies widespread damage to various areas of the brain that mediate language functions. So, because it is, again, a global, it impacts or it results from various areas in the brain, that requires an extensive damage to many areas in the language hemisphere or the left hemisphere, which is responsible for language functions. So mostly the damage is caused by, at that level of the damage is caused by the damage to the middle cerebral artery. And that, if you, let's go back, sorry to flip back and forth, but let's go back to the circulation, and you could see now here, all of this hemisphere here, the blood vessels here that you see, that is the middle cerebral artery. All of that. So you can see that it supplies a lot of the frontal lobe. It supplies the parietal lobe. It supplies the temporal lobe. It basically, if that happens in the left hemisphere, you are speaking about this lobe, this blood vessel from the beginning here, from the beginning, the lower level being blocked or being damaged. And you imagine now how extensive the damage is. Most of the hemisphere is damaged. Most of it. I'm not saying all, but the language areas definitely are supplied by this very critical artery. So that is the global, caused by the damage to the middle cerebral artery. The results, the damage affects multiple regions in the brain that are involved in language reception, language like comprehension, receiving the input for language and processing that input or comprehending it. And there's a video here that will show you what how the language is impacted, and that shows a real patient with global aphasia. The characteristics of it combine Broca's aphasia characteristics. The person will have, for example, difficulty speaking grammatically, They will have difficulty processing very complex or indirect grammar. They will pause, and they will have difficulty retrieving words, and the speech will be slow and labored. They will also have Wernicke's symptoms, Wernicke's features. When they cannot process well, they cannot monitor what they are saying. They have no awareness that their speech is impacted. And they also have conduction aphasia. So all of these three, Broca's, Wernicke's, and conduction, are mostly all present in global aphasia. These include comprehension difficulties and difficulty formulating grammar and difficulty repeating sentences. The person will have severely decreased speech output. Their speech will be limited to just a few words. As a result, the person might try, for example, to repeat, things that they try to say, or things that people say, and they have a lot of repetition. Automatic speech forms, we call them sometimes procedural. That means things that you kind of know by heart. And for example, 1, 2, 3, 4, the numbers. And these are very resistant to memory loss. The alphabet, for example. Certain words that we use so frequently. So these words tend to be automatic or procedural speech forms. These are intact in the patient with global aphasia. For example, swearing. If that person, swears frequently in their life before they have the aphasia. Some people don't swear as much, of course. Counting, that is, again, this from even preschool. Reciting days of the week, months of the year. For example, singing familiar words or musical tones. All of these are preserved because part of that is connected to the motor system, and that gives them, it helps them retain these automatic functions. And these, again, automatic things or word forms that we have all our lives, so they are resistant to memory loss. The person will have severe comprehension difficulties, for example, and they can comprehend just a few words of what is being said. They have, for example, they will be able to comprehend some idiomatic expressions that we use frequently. This is a diagram that summarizes some of the basic features of these aphasias that we discussed. And just keep in mind that a lot of the features that I included in aphasia here may not be in your textbook, and this is why I added them here, so that you can refer to this lecture and get more information about these very important language disorders. When we do assessment or evaluation of aphasia or brain damage, generally the evaluation process, first, as soon as the injury comes, or the stroke or whatever it is, we go and do the evaluation. We take in consideration that there is spontaneous recovery that occurs in the first few weeks, but ideally we want to do the evaluation as soon as the person comes into the emergency room, so that we can determine the level of the damage. And then we will be able to determine the effect or how fast the person responds to treatment, given that there is spontaneous recovery. You will be able to assess and say how much improvement has the person made since the day of the injury. So it's important to go there and do the evaluation, and the results will serve as a baseline. So, for example, when you do the evaluation, It is most often done in the intensive care unit. You want to have an idea about cognitive skills, about conversational speech. So conversational speech, you engage in a conversation with the person and write down everything that they say. And you also have formal diagnostic testing, which is standardized testing. A company makes a test and gives it to many people, hundreds and thousands of people, and and then they say, okay, all of these people who have no language impairment, this is how they performed. And then you take that test and test someone who has a stroke or a brain injury and see how they perform. Compare their performance to the performance of the average or the norms. And based on that, you determine the level of the impairment or if there is an impairment. So that is formal testing. Testing instruments made by companies, and they are tested on or standardized on a wide number of the population, so you can compare. We test for orientation. Typically we do something called mini neurocognitive evaluation or assessment, where you test the person's orientation. Like, where are you? Tell me the days of the week, the year, basic information to know that the person is oriented to, they know what time it is, who they are, tell me, do you have children? Do you have a wife? Who is the president of the United States? What year are we in? And stuff like that. Basic information that any citizen should know. And if they have difficulty with that, you know that they are not yet in full cognitive awareness. When you look at their conversational speech, you look for example, are they speaking in normal grammar? Do they hesitate? Do they pause? Do they take a long time? Are they having difficulty retrieving words? Are they able to monitor if they make a mistake? Do they go back and correct? What kind? Do they make phonemic errors like paraphasias? Do they have difficulty comprehending what you are saying to them? If you take a sentence like the cat ate the fish versus the cat ate the fish, or the fish that was caught by the man was eaten by the fish. I'm sorry, by the girl. Do they have difficulty understanding passive versus direct forms of the language? Reading and written language, you also evaluate that. We give the person a task and say, right, for example, for me, a couple of sentences, or look at this picture, say something, write it down, and see how their writing is and how their reading skills are, because that is typically also evaluated as part of the brain damage or aphasia assessment or brain injury assessment. Your goal is to identify what damage there is, if there is damage, to the language areas. And if there is damage, what level of severity? Is it a mild problem? Is it a moderate problem? Is it severe problem? Or is it moderate to severe, mild to moderate, and so on? And then you identify the specific areas of language that are impaired. Is it grammar? Is it comprehension? And so on. And then you, based on that, you also, the testing that you do, they have tools to enable you to say what kind of aphasia that the person has. Some people who say it doesn't matter what kind of aphasia, as long as they have aphasia, then it is, but again, you speak about this, you learn more about these kinds of aphasia, and if it is relevant to say Broca's aphasia, Wernicke's, or simply just aphasia, you study that when you go to grad school. So once you have done the evaluation and gotten all this information, part of that assessment, you need to know the goals of the patient. Goals can be different. Let's say the child actually, it's a child who had the aphasia, who had the stroke. Children do have strokes. Stroke is not limited to adults. Children even have a stroke even at birth. But of course, these are rare compared to the fact that most strokes occur to adults. But let's say the stroke or the head injury, for example, that someone had damage because of an accident. If that stroke or damage to the brain, traumatic brain injury occurred or occurred to a child, what will the goals be? The goals, you develop the goals with the parents. The goals usually are to improve social communication, number one, to improve the ability to use language to achieve basic needs in life at first. That is the most important thing. You want to teach the person, for example, to see if they can ask for something. You go to a restaurant and say, I would like to have this meal or that. Are they able to make a request? I would like to use the bathroom. So you look at the most basic skills, if they are there, and then if they are, what are other skills they have? And based on what they are missing, you develop the goals. So for example, a child who has a stroke and they have a language impairment because of the stroke, and let's say the child has no difficulty saying, I would like to use the bathroom, I would like to do this, and basic needs are there, then you say, what is the effect of that language disorder, of the aphasia in this child? What is the effect of it on school performance? So your goal now is to enable the child to maximize his or her performance in school, for example. Maybe this is an adult and this person is playing sports and had the damage. And then you go and say, okay, how can I get the person to go back again to practice that sport? Is he ever going to be able to go back to his sport? How is he going to be able to use language to negotiate social things and a conversation and interaction, to understand what the other players are doing and so on? So the goal here may be to rehabilitate him to go back to practice his sport. Maybe he will never be able to because of other motor problems that accompany the language difficulty. Then in that case you say, okay, my goal is to enable him to succeed in college, to do well in college as much as possible, to have a good positive social interactions. So based on whatever the need is, you make your goals and you begin with the most basic needs and then go up to work or to academics or to whatever goals there are. But in any case, you must develop these goals or must work with the patient himself or herself to develop these goals. You want to know what is the most important thing for them, and you start with it, and then in the process you put the other goals that they want to improve. So intervention should be patient focused. You want to know what are the most important skills for them. Maybe the most important skills are to do well in school. Maybe to go back to work, because they cannot go back to work unless they have, intact functions again, or at least they can manage work demands. Maybe they want to do well socially. So whatever that goal is has to be developed with the patient, and you should be the one to guide the patient as to say, tell me, what are the most important goals that you want to work on? And then you make a priority list and say, this is goal number 1. I will begin my treatment with goal number 1. And then you go to other goals. So in treatment, speech pathologists work to empower the patient so that he or she can communicate successfully. You want to tell them, explain their strengths. You say you are able to do this and this and this, and the areas of difficulty are this and this and that. We want to enable you to reach this level and so on. And also part of it is to connect them with social groups that they can meet with, so that they can have some support, because these groups are very effective. When you know that you are not alone in this world, you have these groups who will provide you with supports, and also you can interact and have communication partners, and they do aphasia groups, and they are very helpful. The goal of communication, the more you communicate and enable the patient to communicate, the more that you activate neural pathways and neural networks, the more, remember, when there's brain damage, whether due to stroke or traumatic brain injury or whatever, the brain experiences a high wave, a great wave of neural plasticity. It opens itself up to improvement, to rebuild, to rebuild skills in these areas. So when the intervention is provided early, very early, as soon as the person is able to receive the treatment and the assessment and the treatment, then the earlier you receive it, the better the outcome is gonna be. Again, because remember, spontaneous recovery, that means that the brain has a window in time where it opens itself again and say, okay, I am ready for rebuilding, I'm ready for improvement. So the structures will be flexible again around this area where the damage is, and with treatment, you can get the maximum improvement. You can reconnect the brain networks in that particular area where around the area where the damage took place. Speech pathologists work to help the person identify cues like gestures or facial gestures or hand gestures or whatever gestures in the environment, that you give them prompts, for example, using a picture or a phonemic cue. For example, you say the patient wants to say bottle, but they look and they don't know how to say it. Say, okay, this is and then you make a first sound, and then, bottle. Some people benefit from that. Or phonological rhyming, for example. Sometimes people use certain rhyming tasks to enable the patient to come to more spontaneous language skills. You teach them compensatory strategies. For example, a patient I worked with many years ago had a global aphasia, and he was just almost nonverbal. So there was a lot of frustration. He wasn't able to communicate to his wife and say what he wants, and their goals were that he could just basically tell his wife and his kids his basic needs. So the first word or the first kind of communication task I worked with him on was to show him how to say yes, no, or I am not sure. So for yes, we worked on this. Yes. So his wife would show him a menu, for example, say, would you like to have this for lunch? He would say yes or no. And he was able to say, and would make some vocalization with that. And you could see on his face enthusiasm if he liked something or no. And then we taught him to go like this if he wasn't sure. So that is compensatory strategies, using nonverbal gestures to be able to show agreement, disagreement, or not sure. One basic goal of treatment is to improve the areas that the person has difficulty with. So because of insurance and because of you want to maximize the benefit, and you also want to capitalize on that window of spontaneous recovery, you want to focus on the problem itself more than the areas around the problem. So you kind of, you have identified the areas that are intact, and then the areas that are not intact, and you focus your treatment on the areas that are not intact. In some cases, when the damage is severe and the language is severely impacted, then you consider augmentative communication system, and many schools, grad schools, provide a course that focuses on augmentative communication, which is basically using technology or using even a communication board to enable the person to convey his or her needs. And the technology now has enabled us to develop some amazing augmentative communication systems. There is, for example, supported communication for aphasia. There are ways where you focus on training conversational speech partners who they come and they interact with the person regularly so that they can provide chances for that person to practice language and to improve. So these people are trained professionals who work as communication partners, because the idea is that the nervous system is flexible. At this particular time, is so much more flexible. And the more you practice language, the more you practice speaking, the more that you can achieve, the more impressive the treatment outcomes will be. So we, try to maximize language usage through conversational partners. These can be family members, these can be speech pathology students, for example, or anyone who basically can engage in a conversation with the person. And that is also low cost, so that can maximize the effects. And the treatment with the speech language pathologist, provides the guidelines and also the main aspect. However, you want to you might be able to do like 2 or 3 times a week, but you want the person to practice communication day by day by day. And the conversational partners will be very helpful. So there are disorders that are comorbid, that may be comorbid with language, with aphasia, language loss. For example, the person might have, if the person has right hemisphere disorder, there are certain parts of communication that are mediated by the right hemisphere. These include processing of lengthy chunks of speech. In conversation, when we speak for 5 minutes, you'll be amazed. Yes, I might say something, you say, yeah, really? But for 5 minutes, as we speak, I need to remember what I said 5 minutes earlier, what you said 5 minutes earlier, what I am going to say, and then focus also at the same time on what you are saying. So I am doing multiple functions. So the right hemisphere in that case processes the emotional content of speech, and it processes the conversation as a whole. And it enables us to just focus on what is being said now in the context of what is said before, what is going to be said after. So in that case, I need to remember what I said before, so I don't make contradiction. Like if you say, when is your meeting? I say Wednesday. And then later in the conversation, when I'm going to the meeting, I am going to do this and that, and say, when I go to the meeting on Thursday, and then you say, what? You just told me Wednesday, and now you're telling me the meeting is on Thursday. So I need to remember, I need to focus on the different aspects of the conversation, so whatever I say doesn't contradict what I said before. And it doesn't contradict, for example, it connects with what you are saying as a listener or as a speaker yourself. The right hemisphere stroke is going to cause difficulty speaking in a normal tone. The person's speech could be flat and will be just robotic, and the person will have difficulty creating melody of speech. The person will have sensory neglect most often. That means that, for example, in the right hemisphere here, it controls the left side of the body. That includes the left half of your face is controlled by the right hemisphere. So, for example, as the person is speaking, or when they look and the right hemisphere is damaged, they could have neglect where the left eye cannot see anything, and then the right eye only can, the right eye only can see. So if you ask them, show them a flower and say, I'd like you to paint, draw a flower, or draw this flower that I'm showing you, they could just draw half of the flower and leave the other half. Draw a clock, they will draw half of that clock, half a circle, and then the other half is missing. So that is called visual neglect, and it often occurs as a result of right hemisphere. We call it visual neglect. And sometimes the arm might be impaired as a result, or the leg. And again, the person will have difficulty with lengthy chunks of speech, with conversation, or with telling a story, connected speech, or with comprehending a story that someone else is saying, because the right hemisphere is specialized in narratives. Your ability to produce a comprehensive narrative, or your ability to comprehend a narrative. And narratives are part of discourse skills, conversation, or the ability to give a lecture, or the ability to give a description of a story, or to tell a story. In traumatic brain injury, the person will have difficulty with cognitive processing, coming up with ideas, understanding jokes, using language, pragmatics, using language to give and take with people, to, for example, ask questions, to comprehend what other people are saying. They will have difficulty with word finding or remembering words. These are very common deficits in brain injury. Dementia is caused by age, and the most common form of dementia is Alzheimer's. So Alzheimer's disease is the most frequent etiology, or the most frequent cause of that kind of dementia. Sometimes in the past it was called senile dementia. But anyone who lives long enough is going to have some form of Alzheimer's. But when we diagnose it and say someone has Alzheimer's disease, that means that it usually occurs earlier, like sometimes even in the 50s or in the 60s, where if someone has dementia when he or she reaches 90 years, that could be definitely understood as an age-related. There are also progressive degeneration. In dementia, there's progressive degeneration of both hemispheres, right and left hemispheres. And you can think of this as geological layers. Like the very, very top layer, for example, in geology, is formed last. And so dementia or Alzheimer's disease, it hits the most recent functions first. And then, so for example, someone has a college degree, bachelor's. The senior year information is just disintegrated first. And then junior, and then sophomore, and then freshman, and then you come to high school knowledge, and it gets peeled off, and then middle school, and then, so the most basic are the early skills, then they become lost after. So that's progressive degeneration. And they tell you, the more knowledge you have, the less, or the slower the effect of the dementia or Alzheimer's disease will be. Like if you have a doctorate or a PhD, by the time that deterioration comes and takes place and takes off all this information, then you still have, a lot of information from your master's or a lot of information on that bachelor's level and so on. So in one way, people who have lots and lots and lots of knowledge, the effect of dementia or Alzheimer's disease on them will be slower because they have a large bank of knowledge and it takes longer to deplete that bank. The people would have difficulty with working memory. That's the kind of memory that enables you to focus on two tasks at once. For example, you are walking and talking. That's a very basic skill. And people with dementia or Alzheimer's disease, they would have difficulty doing the two tasks at once. As you walk, they kind of hold you and, oh, this happened. They hold you and stop. And they listen and talk. And then you walk again, and they can't process walking and talking at once, for example. Difficulty with orientation, difficulty with reasoning skills, and difficulty making judgment. What do you wear? Do you put your pajama top? Do you wear it on your feet? Or do you wear it front and back? And even clothing. But that comes at the very end. In the last stage, the person has difficulty getting dressed and figuring out what a shirt is and how to wear it, what pants are, how to wear them, and so on. So again, in summary, we spoke about damage to the brain, and that damage in the context of how it impacts communication. We spoke about cerebrovascular accidents in terms of hemorrhagic strokes or occlusive strokes and how they affect the brain and what kind of and how the aphasia can result. We spoke about what an embolus is, what a thrombus is, hemorrhage, aneurysms, and then we also spoke about traumatic brain injury and how it affects right and left hemispheres. And we spoke about aphasia, which is language loss or language impairment that is caused by a cerebrovascular accident. We discussed various, some of the kinds of aphasia, including Broca's aphasia, Wernicke's aphasia, conduction aphasia, anomic aphasia, transcortical aphasia, including sensory and motor. We also spoke about global aphasia. So these are 6 kinds of aphasia that we spoke about. And then we discussed very broadly how we do the evaluation, and we discussed aspects of treatment. There are various treatment methods for aphasia, and you will learn about all of this when you go to grad school and you study aphasia and related disorders. That's a big course that you have in grad school. So I hope that you find this presentation helpful. I hope that you pause it, you go back to it and pause it and listen to different parts of it again. And I'll post this for you. So thank you.